all his Packer friends that if they should lose next week to the Bears, it would have been better that they lost last week, so they would not have to lose to the Bears. So it's doubly important that the Green Bay Packers win next week. But I say that to introduce him, partly for you to know this, that Professor Camosy is from Kenosha, Wisconsin, which is on Lake Michigan between Milwaukee and Chicago, just over the border of Illinois into Wisconsin. He grew up outside of Kenosha by the cornfields in Wisconsin. He gravitated southward a couple hours when he went to college, going to Notre Dame, where he was a philosophy undergraduate. He then went on to stay at Notre Dame to do his master's in theology on the Trinity, but then moved over into areas of ethics and medical ethics for his doctoral work. So Professor Camosy, under the common parlance in America, is known as a triple domer. And that a domer is one who does a degree at Notre Dame. A triple domer, which is relatively rare, is one who did 3 degrees at Notre Dame. Since that time of graduation from there, Professor Camosy has gone on to teach at Fordham University, a fine Jesuit institution in New York City. And just a couple of weeks ago, his first book has been published, Too Expensive to Treat, Finitude, Tragedy, and the Neonatal ICU, Intensive Care Unit, or the NICU. It's just been published. As well, Professor Camosy has published a number of articles that have already appeared in various scholarly journals. In addition to his work in medical ethics, Professor Camosy is at the forefront of an attempt of a new kind of dialogue to go on in American society. Being a true domer, he listened attentively when President Barack Obama gave a commencement address at Notre Dame a couple of years ago, in which the President of the United States called for renewed dialogue in America over its most controversial issues. And so Professor Camosy did not shy away from that and decided to begin with the most controversial of all, and to start a major dialogue on the question of abortion, which culminated in a conference at Princeton University last October. Unfortunately, it was the same weekend as the Lupina Center conference, so I wasn't able to go or participate in that. But it brought together really the leading both pro-life and pro-choice intellectual advocates, including people like Peter Singer, John Finnis, and a variety of really interesting and important thinkers across the spectrum. And so Professor Camosy is certainly to be commended for his, and he organized that conference and really had the idea for it and got it going. So Professor Camosy is doing really interesting and wonderful things, both in healthcare ethics and in larger ethical questions as they affect North American society. And so tonight, Professor Camosy will be speaking on issues related to his book, specifically on the duty to ration healthcare from the perspective of Catholic social teaching. And one other thing I want to mention is that tomorrow afternoon, Professor Camosy will be doing a graduate seminar here at Regis on articulating the value of suffering, insights from focolare spirituality. So if you're interested in that, we have the readings here for that. If you would like to come to that and would like to be able to do the reading for that, we have a couple of articles for you to read to prepare for that if you'd like to be a part of that. And that's here tomorrow afternoon from 2 to 4. Without further ado, I welcome Professor Camosy.
Thanks to John and the Lupina Center for hosting me, and thanks for all of you being here. I suspect that a crowd that shows up to this kind of talk is a bit self-selecting, and probably if you're here, you know something of what's been going on in the United States regarding healthcare reform issues over the last year and a half. And if you have been paying attention to that, you know that Canadian healthcare is invoked many times during our American debates, either as friend or foe. Usually it's one or the other. And often the people who invoke it don't quite know exactly what they're talking about. I would actually include myself in that. So my first thing I want to say is it's a disclaimer. I am not a student of Canadian healthcare. I know something about it. I know probably more than the average American, I hope, about it. I think that's probably right. But I'm not a student of Canadian healthcare, so I hope if there's anything relevant to my talk tonight that connects to something I'm missing about Canadian healthcare, I hope that comes out in the question and answer session. Happily, I don't think a lot of my talk tonight is in fact going to be connected to those kind of specifics, but I just want to throw that out there as a disclaimer. So here's my plan. Here's what I want to talk about. I think most mistakes in ethics come from a misunderstanding of the human person. And so I want to start there. What is a human person from the perspective of Catholic social teaching? I'll also invoke some insights from focolare spirituality to help shed some light on this topic as well. I'll have more to say about that in the graduate seminar tomorrow, but that'll be part of what I'm talking about. Second, I'll talk about some general ethical implications of that anthropology, or that understanding of the human person. And third and finally, I will discuss this understanding's implication for how we should think specifically about distribution of healthcare resources, and on three different levels. Pardon the analytic philosopher me, I like to divide things into three. So, the level of the broad healthcare system, distribution of healthcare resources at that level, the level of the clinic, and at the level of the individual patient making a decision. So those are the three levels I want to talk about distribution of healthcare resources. Most importantly, perhaps, I want to leave lots of time for question and answer. So I hope you form some critical comments and questions, and we could spend a good deal of time having some exchange. In fact, when I teach my courses at Fordham, I tell them I actually make my students participate at a level such that 25% of their grade is class participation, so they're sort of forced to do it. And I don't mind that at all. But it is odd that I'd be, in most circumstances, be up here talking for 35, 40 minutes at any particular time. All right, so the human person. What does Catholic social teaching have to say about the human person? Well, the first point to be made is one I'm sure you've heard numerous times. It's that human persons have dignity and value because they are made in the image of God. Now, I don't want to get into the arguments about moral status and what precisely that means in some of the questions, especially the ones we went over at the Princeton conference. By the way, to have Peter Singer and John Finnis talk about this was just unbelievable. It was just an amazing time to see those two giants go at it. But anyway, let's just stipulate that as part of what Catholic social teaching has to say for our purposes tonight. Then this dignity and value cannot be reduced or used for some other goal or means, right? So the value and dignity of human persons is irreducible. Now, what that means in the abstract will become a little bit more clear. What it could possibly mean in the abstract will become a little more clear when we start applying it to the things I'm going to apply it to tonight. Okay, first point. Second point. However, though individuals do have irreducible dignity, this dignity is not individualistic. This value, in fact, can only make sense in a social context which necessarily considers the dignity of others. Indeed, we are intrinsically social creatures. Our good is dependent on the good of others and vice versa. This is especially true, though not only true, in today's globalized world, or at least for those of us who are connected in the globalized world. But it is a very countercultural thing in secular society today, I think, which tends to primarily value individual freedom, privacy, and choice. All right. And then a third point about what a person is from the perspective of Catholic social teaching, and it's something you think that we would hear more often, it's that we aren't God. We are finite. We have finite natures, and by the way, we also have finite resources. One would think that Christians would be better at making decisions with this truth in mind. Turns out we aren't so good at that, at least especially, or maybe especially in the United States. But I suspect that in most liberal Western democracies, Christians have sort of bought into a different kind of understanding of the human person. Okay, so what are some general implications of this understanding of the human person? Again, not specifically talking about distribution of healthcare resources now, we'll get to that in a few minutes, but what are some just general ethical implications of this understanding? Well, the first one, connected to the first point, is that it's never right to aim at death. So we cannot use someone's death as a means to some other end we have. This reduces the irreducible value of lives of persons, and at least from the perspective of Catholic social teaching, it will always be wrong. But it's complex, right? So what does it actually mean to aim at death is a really, really complex, difficult question. A lot of this gets parsed out. We're gonna try to parse it out with regard to distribution of healthcare resources. But a way it gets parsed out a lot, at least in ethical issues, is with regard to killing others in war, right? So the difference between a terrorist, at least in theory, and a bomber pilot who's aiming at a military installation might be that a terrorist uses the death of civilians as a means to her end, right? Reduces the irreducible value of a person for some other means or goal. Now, consequentialists are going to say that there's very little difference between a terrorist and a bomber pilot because with collateral damage, they're both killing civilians. However, from at least this perspective, it's at least in theory different because a U.S. or a Canadian bomber pilot might not aim at death, might not use the death of civilians. They might only foresee but not intend their death. Right? And this is the classic application of double effect. So with my students, I talk about the PIST test, right? So are you going to be upset if civilians aren't killed? The terrorist is going to be upset if civilians aren't killed. The bomber pilot is not going to be. In fact, they would be overjoyed, right? Because their target is not civilians. So I think that sort of test is really helpful for trying to figure out what exactly is going on in one's intention. Okay, so that we'll come back to that, but that's an important point. What's another general implication of this understanding of the human person? Well, another point is what is good for someone or in someone's best interests can never be isolated from a broader understanding of that person's network of relationships. So remember, this harkens back to the human dignity is irreducible, but it's not individualistic. So indeed, my social duties to my neighbor are in fact part of my best interests from the perspective of Catholic social teaching. Though from a narrow secular individualism, it looks like it might be against my interests. So for instance, we just got done having yet another debate about taxes in the United States, whether they should be raised or lowered. From a number of people making this argument, it was just understood that taxing them must be against their best interests. After all, it takes away money that they could use for things that they would consider to be in their interests. But if you consider Catholic social teaching, your duties to others, your duties to the common good, are part of what your interest in fact is. It's a false dichotomy to make the distinction. I think these insights of the human person tie directly towards the Focolare's spirituality of unity. And perhaps some of you are actually wondering what the Focolare is. It's actually a lay Catholic movement, relatively young lay Catholic movement, founded by a woman named Chiara Lubich, who with her friends in a bomb shelter in Trento, Italy during World War II, as the Allies were pounding northern Italy as fleeing German soldiers were trying to make it out of Italy. In the midst of that tragedy and suffering, they asked themselves a profound question, and one which gave birth to a vigorous international lay movement. And the question was this: what if people actually loved one another? Another very simple question, doesn't get asked enough. I mean, in today's culture, people say, okay, love one another. Isn't love sort of a passé, empty concept? Who's against love, right? And if everyone is for something, then how can its invocation actually be helpful when people disagree? But Focolare is very specific when they talk about what they mean to love. They come out of a Christian tradition which notes that Christ commanded us to love others as God has loved us, right? So it's a very specific kind of love, as God has loved us. And in light of Christ crucified, Kiara Lubick said, that means you need to love such that I am ready to die for you, and vice versa. And if we are to love as God loves us, we are to model a Trinitarian kind of love. Christians believe in a triune God. And this kind of love recognizes that our real diversity presupposes an intrinsic unity. Indeed, the organizing principle of the Focolare movement is Jesus' prayer that all may be one, just as the Father and Son are one. Okay, this may all sound nice, but for those of you who aren't academics who are here, just as the general public, I'm an academic, I guess, but I often have this reaction too. I would say, okay, is this all just academic, highbrow intellectualism and spirituality? Does this actually matter, right? Where does this matter? Where does this hit the ground in some specific way? And furthermore, isn't this supposed to be a talk on distribution of healthcare resources? Have we talked about that yet? No, but we're getting there. And quite frankly, I get annoyed with the tendency in the academy too to intellectualize without being able to connect it to situations where the rubber meets the road, which is why I wrote this book on the neonatal intensive care unit. That's about where it meets the road in some dramatic ways. But one of the things I love about studying and teaching academic ethics is you get to do the intellectualism, but then you also get to connect it to the lives of real people and to issues that really matter to real people. But let's talk about those things. Where does this matter, especially for the topic of tonight's talk? Well, let's start with the individual dignity of the human person. It means, among other things, as we said, that it's never morally acceptable to aim at the death of an innocent person. One could never have death either as the goal of one's action or the means by which one accomplishes that goal. The church claims that it is intrinsically evil because it takes someone of irreducible worth and uses them for some other purpose. So for our topic on distribution of resources, it would rule out saying that I will kill you in order to save money, right? Because what's that doing? It's using the death of a person for some other means. So in the United States, when we discuss these things, somebody invokes the term death panels, and this is what they have in mind, right? So in the debate over the United States healthcare reform, those who oppose it or oppose where they think it's going say we are going to lead to situations, this is going to lead to situations where we will do precisely this, where we will kill individuals to save money. That would be absolutely prohibited from the perspective of Catholic social teaching because it uses the irreducible dignity and value of the human person for some other means or end. Always going to be wrong. What might be okay, however, is to say, I will not provide you aid because doing so would be disproportionate and therefore an unjust use of resources. And in fact, this happens in medicine sometimes. Not all the time, but it happens sometimes. Especially when it comes to triage medicine or disaster medicine, right? One of my friends is on a task force to determine what happens in New York City if there's a natural disaster and we run out of ventilators. Who gets ventilators? On what basis do we decide who gets ventilators? Who gets to decide on that basis? Now, the argument is not if you decide not to give a ventilator to someone who will die without it. I want to kill you to save resources. The argument is, from this perspective of triage medicine, we have a limited number of ventilators, and it's disproportionate to spend it on someone. So someone might say, somebody who is likely terminal and going to die in a few hours, we should not give them a ventilator if we could give it to somebody whose prognosis is dramatically better, right? Now, is that a situation where we are saying I will kill the person with a poor prognosis to save money? Absolutely not. In fact, let's use the PISS test, right? Let's say the prognosis was wrong and we didn't give that person the ventilator. Would we be upset that the person died? Absolutely not. We would be overjoyed. We would be thrilled. So their death is not being reduced or used as a means. Using double effect language, it's the unforeseen, or it's the foreseen but unintended result of our action, effect of our action. Of course, you need a proportionate reason to do that, and that's where some of the rubber hits the road, and that's where triage medicine, especially in disaster medicine, is such a messy thing. Difficult, really difficult thing. But one of the central points of my book is that actually all healthcare resource distribution is triage. And what do I mean by that? Well, if you just simply define triage as a situation where healthcare needs outstrip healthcare resources, and you have to find some mechanism for deciding who gets what, that's human experience, right? That's what we have going on. That's admitting that we have finite natures and necessarily then virtually unlimited healthcare needs. As my favorite Onion article, I don't know if you guys are familiar with the Onion up here, but it's a sort of this sarcastic, ironic newspaper. My favorite Onion newspaper headline of all time is "World Death Rate Holds Steady at 100%." So you combine that with the fact we have radically limited resources, and not just in healthcare. I mean, especially if we're trying to fund education, defense, any number of things, we have a limited amount of resources. And so one of the central points of my book is we will never not be rationing healthcare. We are in a de facto triage situation right now. And we're not going to get out of it. It's part of what it means to have a finite nature and finite resources. Okay, so now what? Well, let's talk about the implications of the intrinsic social nature of the person, and in particular the Focolare's spirituality of unity, and apply it to distribution of resources. Well, I think if you take that seriously, if you take what I just said seriously and combine it with the spirituality of unity, I think you have to come to the conclusion that one's personal right to healthcare can only be seen in the context of how one's consumption of healthcare affects the broader common good. And especially the good of the most vulnerable. Classic example of the Focolare spiritual practice of paying special attention to loving Jesus forsaken in our neighbor. The most vulnerable, I think, definitely fall into that category. The suffering and vulnerable and those without anyone to care for themselves have to be primary considerations when deciding how we're going to distribute healthcare resources. And I would argue, therefore, one must be prepared to ration healthcare in the interests of justice, even if it means foregoing life-sustaining treatment. Preserving life at all costs is the very definition of idolatry. Even in the neonatal ICU. And this is what I tried to write a provocative book, so I decided to do it. You could apply this argument to any level of healthcare, any kind of healthcare, but I think we have to take seriously that it might mean making some very, very difficult decisions. But let's get even more specific. What sorts of difficult decisions? Remember, I wanted to apply this to 3 different levels of healthcare resource distribution. The macro level, the design of the healthcare system itself. One step down, the level of the clinic, clinicians making individual decisions. And then a 3rd level, individuals themselves making decisions about their own healthcare needs and choices. So let's start with the macro level. Obviously, we need to plan a health care system, and we should do so with everything that I just said in mind, how would that work? Well, Canada, I think, I don't need to be telling you this, I think does maybe the least bad job of this out there. The United States does it somewhat as well, though. I think the United States sometimes gets a bad rap for this. We do have two programs called Medicaid and Medicare, which are government-run health insurance systems. Medicaid is generally for the very poor. Medicare is for those who have retired and who aren't able to purchase, or at least in theory, for those who aren't able to purchase health care insurance once they've retired. One of the problems is Medicaid is so overstretched in its budgets, it can't really meet. Those who Medicaid actually covers aren't getting the kind of care that they actually need, and Medicaid doesn't cover nearly enough people who can't afford to buy private insurance in the United States, which is one of the whole reasons for this big debate we had over the last year and a half. However, though our resources are indeed limited, especially when part of a market-driven system, I don't think we need to, saying they're limited, I don't think means that they need to be determined as static or fixed. Medicaid and Medicare and the individual provinces' healthcare systems here in Canada, they work from fixed budgets every year. That's a fixed amount of money. But I think if you're thinking about the whole healthcare system, I don't think we have to think about resources. We have to think about them as limited. We'll never have unlimited resources. That's just idolatry. But I don't think we need to think of them as static or fixed necessarily, and that's where the market really helps. I think the market helps generate resources through efficiency and innovation. I'm no health economist or health resource economist, but it doesn't seem obvious to me that those who reject a single-payer system are obviously wrong. I don't think they're obviously right, but I don't think they're obviously wrong either. I think it's complicated, and I think we need more information about how precisely innovation and efficiency are connected to the market, and how a regulated market, of course. But I think one can at least make a plausible argument, maybe this would be fruit for question and answer after the talk. I think one can at least make a plausible argument that a vigorous healthcare market, regulated in such a way that it produces innovation and efficiency, is an essential part of a healthcare system. Especially if you think of future technologies and future efficiencies as being owed to future generations. This is one of Benedict XVI's, I think, most important new ideas, or at least newly highlighted ideas, and that's the concept of intergenerational solidarity. He talks about it most in terms of his ecological ethics and what we owe future generations in terms of how we are stewards of the world around us. But I think it could also apply here. What does it mean to be in solidarity with future generations when it comes to providing the best opportunities possible to generate new medical technologies or new medical efficiencies? I think it's at least an open question that we need to keep thinking about. And maybe we could talk about it in question and answer if you like. All right, let's go to the clinical level. As the Lupina Center's conference that you had in October talked about, medicine is a practice. It has its own internal ends and goals. As I tell my students, medicine is not like Burger King where you have it your way. Medicine in some way is about the healing and mitigating, healing of and then mitigating against disease, which is why I tell my students it's odd that we would consider plastic surgery or birth control abortions as medicine. People trained in medicine might perform the action, but to call them medicine seems rather strange. They don't seem to be, I mean, I suppose some kinds of plastic surgery might. If someone gets into a car accident, that kind might. Some abortions might, if a person's health or life is in danger. But most plastic surgeries and most abortions don't seem to be about healing disease or mitigating against the disease. So many philosophers and ethicists, if it's in fact true that medicine is not just a transaction between two people, but a practice, a professional practice that has its own internal ends and goals, many say, well, one of those things is that it's a one-on-one relationship between the healthcare provider and the patient. So one of the internal ends of medicine has to be that the healthcare provider focus just on the patient in front of her and not be worried about all the other social questions, distribution of resource issues that might be acceptable on the macro level or the level of the institution. In the clinic, that's got to be one-on-one. As you might imagine, I think, well, I just think it's more complicated than that. Surely this is a good rule of thumb. Some of the worst abuses in medical ethics, and in fact the birth of medical ethics, can probably be traced back to an abuse of precisely this principle. Nazi physicians worrying more about what they considered to be the common good and overriding the intrinsic dignity of their patient in front of them. That's sort of radical evil that sort of was, the conception of that led to the conception of medical ethics as a discipline, as an idea, came from ignoring precisely this principle. So surely it's a good principle. But to say that it has no exceptions, I think is also takes it too far. I don't think physicians or healthcare providers are exempt from what it means to be a human person. And the dignity of the human person is intrinsically social. To see the good of your patient as entirely disconnected from the good of others is anthropologically false. It's anthropologically wrong. Healthcare providers are not exempt from criticism of thinking about someone's good from a point of view that's too individualistically narrow. Indeed, medicine, despite the majority of ethicists and physicians speaking about the good of the patient in front of them, medicine too seems to have been corrupted by this false and illusory individual anthropology of secular liberalism, but in fact, it doesn't happen all the time. In fact, in some medical ethics, in some medical contexts, precisely the opposite happens. We already talked about triage medicine. Nobody says, oh, well, the battlefield doctor or the ER doctor who's apportioning ventilators is somehow not practicing medicine if they see the patient in front of them and say, okay, I'm not going to give the ventilator to you. No one says that. In fact, they're some of the most heroic practitioners of medicine out there, at least from my point of view. I would never want that job. And even in a less dramatic situation, I don't know how it works here, but in the United States, it doesn't happen often enough, but physicians are now starting to refuse to prescribe antibiotics to their patients every time that the patients demand them, even if that antibiotic could improve that patient's health situation. Why? For the good of the community. They don't want to create super resistant disease that are resistant to the antibiotics. And no one says, oh, that somehow violates the ends of medicine. You got to only care about the patient in front of you. This antibiotic could cure the patient in front of you, or at least cure them quicker. And you're worried about the community or something? No, this is accepted medical practice, even in the hyper-individualistic United States. Now, some might argue, including my friend who works on the disaster preparedness task force for New York, she says something like, well, at least in theory, maybe when it comes to distribution of medical resources, it could work at the clinical level. Decisions could be made at the clinical level. But in fact, the individual physician in the ER has no idea what's going on in terms of what would be just distribution of resources. So why would we trust their judgment when it comes to that? We should leave it to the macro level for this to happen, right? What I like to say to her is, I just don't know if that's true. In fact, in some way, I think you need both. You certainly need to know what's going on at the macro level, but to make a decision about an individual patient, you can't do that from the top down. There's got to be some level of clinical understanding of this specific patient's situation. And in fact, if you do it from the top down without the clinic being involved, sometimes some strange things happen. The Medicaid program in Oregon, the state of Oregon in the United States, several years ago, decided that they would ration their resources in the following way. They would come up with somewhere around 150, 160, maybe more, generic disease states like cancer, pulmonary disease, cystic fibrosis, AIDS, even thumb sucking was one of them. And then they'd rank them and talk about the cost-benefit analysis, and a computer was involved. And then they'd draw a line, and then everything above the line was covered by Oregon State Medicaid, and everything below the line was not covered. That was one of the things they decided to do. Turns out the macro level distribution of resources ended up putting thumb sucking ahead of both AIDS and cystic fibrosis. So if you had cystic fibrosis and AIDS and you were on Oregon Medicaid, too bad, so sad, but if your child has a thumb sucking problem, you're good to go. So I think that's a classic example of why it can't just be the top-down macro level decision making. There's got to be some other element involved. And one of the levels might be the clinical level. A final level, and this will be my final point, and then I'll conclude, would be the individual level. So what about actually refusing health care for oneself in the interest of the common good? Nothing that's been said so far, at least as far as I can tell, seems to run against this idea, as long as you're not aiming at your own death in a certain way, right? You're not using the value of your own life as a means to some other end. And indeed, much seems to speak in favor of it. Indeed, if one has a duty not to use resources in a way that is disproportionate with the common good in situations like, I don't know, luxury or energy, education, fill in your favorite overused, disproportionately allocated resource. If you have a duty in those situations to not use resources in a way that's disproportionate with the common good, why would healthcare resources be any different? Perhaps we should be doing this out of our own initiative in a certain way. Now, obviously, this sort of renunciation works best where our renunciation would clearly benefit someone else. So, like in Medicaid or Medicare or in Canadian Providence's systems where you have fixed budgets, if you don't use something, then you can be pretty sure it's going to help somebody else. That's a little more complicated in a private system where the fixed budgets aren't clearly there. But I do think even in the context of private systems, it could work in trying to turn the tide in how healthcare dollars are spent. So in the United States, for instance, I think we just need more primary care and less MRI scans. And if our medical choices can turn the tide when it comes to that, with regard to private systems, I think that would be all to the good. But the classic example might be an organ donation list, right? So could you ever imagine a situation where you or someone else who was on a list, who might come to the conclusion, no, I've used a significant amount of resources, and it's time that somebody who hasn't had the access to the resources that I've had get access to the organ before me. I think if we truly believe in the understanding of the human person that Catholic social teaching gives us, we at least have to be open to that question. So let me conclude briefly with what I take to be the bottom line. We live in a fallen, tragic world. And this means dealing with difficult decisions and not running away from them. Shouldn't Christians be among the first to bravely face such difficult challenges? I think the answer is yes. After all, we know that our dignity only makes sense in relationships with others. We know about the finitude of our natures and of our resources. And even in the face of an extreme tragedy, we know that there is not a greater love than this, to lay down one's life for one's friends. Thank you.